Hello and welcome to Module 2 of the training on the MMPI-2 Restructured form. My name is Anthony Terrascavage and I'll be narrating this module for you all. A little bit of background on me. So I am a licensed clinical psychologist in Ohio. I'm also an assistant professor at John Carroll University, where I conduct research on MMPI-2 Restructured form as well as other psychological instruments. So what is the purpose of this module? Well, what we'll be getting into are a few different concepts. First, we will describe the scales of the MMPI-2-RF, and we will go through all 51 of them. Next, we'll get into the hierarchical structure of the instrument. As we'll see, the substantive scales of this test are structured hierarchically, where we have, on the one hand, very broad measures of psychopathological constructs, moving into more mid-level and more specific measures as we go throughout the interpretation hierarchy. And then finally, we'll discuss the psychological constructs that are assessed by the MMPI-2-RF scales.
The MMPI-2-RF has 51 scales. That's a lot of scales. And the reason we have so many scales on the restructured form is that we wanted to develop a comprehensive assessment instrument. So we have several sets of scales. We have, of course, validity scales that give us information about how the individual approached the test, whether they were able to understand and respond relevantly to the content of the test items, whether there are any indications of over-reporting or under-reporting. And then we have 42 substantive scales. They're organized in a hierarchical structure. The broadest level of measurement, we have the 3 higher order scales. And these scales indicate whether a test taker presents and to what extent with problems in the domains of mood and affect, disordered thinking, or under control behavior. The second tier of measurement is represented by the 9 restructured clinical scales, or the RC scales. And the RC scales are the common denominator between the MMPI-2 and the MMPI-2-RF. They really represented the first effort to restructure and modernize the MMPI clinical scales. And we also have 23 specific problem scales. Those are the most narrowly focused measures on the restructured form and provide information that either complements what we get from the RC scales or augments that information by getting into other domains of functioning or dysfunction. We also have interest scales and another set of scales called the Psy-5 or Personality Psychopathology 5. So we do have a lot of scales on the test, and learning how to take all that information and integrate it into an overall interpretation is a process, but well worth it, because at the end of this process you will achieve and obtain a comprehensive assessment of the individual's psychological functioning.
So let's begin going through all of the MMPI-2-RF scales. You can see here that there are 9 validity scales, 3 higher order scales, 9 restructured clinical scales, 23 specific problem scales, 2 interest scales, and then the 5 Psy-5 scales. We'll begin by discussing the validity scales and the constructs that they are intended to measure.
The MMPI-2-RF validity scales provide the interpreter with important information about how the individual approached the assessment. Were they able to respond relevantly to the test items, or are there any concerns about how they responded? These are necessary, the validity scales are, because with the MMPI, as with any self-report instrument, we're relying on the individual's self-report. Some people are able to accurately report their psychological functioning, others less so, and sometimes people are motivated to either over-report or under-report problems. So we have essentially 3 sets of validity scales on the restructured form. We have 2 measures of inconsistent responding. One would identify any pattern of random responding, or, for example, if the person was having difficulties understanding the items and therefore responding irrelevantly to their content. And another one focuses on whether the test taker provided indiscriminate true or false responses on a repeated basis. We also have measures of over-reporting that tell us whether the test taker, if we were to compare their self-report with a hypothetical objective assessment of their functioning, that they overstated. They either exaggerated or in some cases even fabricated problems. The measures of underreporting, the third set of scales, indicate whether there were any attempts to minimize or deny the significance or the existence in some cases of psychological problems. The importance of the validity scales is that they really tell us how much confidence we can place in scores on the substantive scales to accurately reflect the individual's psychological functioning. In some instances, we may need to qualify the interpretation. In others, not very frequently, but from time to time, we may deem the assessment or the responses to the substantive scale items invalid and uninterpretable. So those are the validity scales that we have for the MMPI-2-RF, and the importance, of course, is in guiding the interpretation of scores on all the scales on the instrument.
The validity scales are intended to assess protocol validity, which in other words is the extent to which a test taker accurately responded to the MMPI-2-RF test questions. Now there's essentially three areas of concern when it comes to protocol validity. The first area of concern is non-content based invalid responding. These are protocol validity issues that are unrelated to the content of the test questions. The first two scales listed on this slide, VRIN and TRIN, are intended to assess this threat to protocol validity. Variable response inconsistency assesses random responding. The way VRIN works is that the scale is comprised of a series of item pairings. And these are item pairings with very similar content. So a hypothetical example of one of these item pairings might be something like, I am sad and I am depressed. If somebody answers true to one of those items in the pairing and false to the other item in the pairing, then they have an inconsistent response, and it's a variable response. And in this way, VRIN is used to assess random true-false responding. TRIN, on the other hand, is designed to assess fixed responding. And here too, TRIN is comprised of a series of item pairs, but in the case of TRIN, the item pairs have opposite content. So a hypothetical example of a TRIN item pair would be something like, I am sad and I am happy. If someone answers true to both of those or false to both of those, then they provide an inconsistent response. But here it's an inconsistency that illustrates fixed responding, either fixed true or fixed false, invalid responding. The next series of validity scales are designed to assess over-reporting, which is the exaggeration or fabrication of psychological or somatic problems. The first three scales that we'll review here are infrequent responses, infrequent psychopathology responses, and infrequent somatic responses. All three of these scales assess over-reporting by way of an infrequency approach. An infrequency approach involves culminating onto a scale items that are uncommonly endorsed by individuals from various relevant populations. The idea here is that if a test taker endorses many of these infrequent items, that they're likely over-reporting. In the case of infrequent responses, FR, this scale is comprised of items that are infrequently endorsed in the general population as represented by the normative sample. In the case of infrequent psychopathology responses, here this scale has a series of items that are infrequent among psychiatric inpatients in particular. And then finally, with infrequent somatic responses, this scale has items with somatic content, in other words, items that reflect physical problems that are uncommonly endorsed among bona fide medical patients. So in the case of FS, elevations on the scale indicate potentially the overreporting and possibly malingering of somatic problems. The next two scales also assess overreporting. Symptom validity is intended to assess somatic and cognitive overreporting. This is a rationally derived scale. And the response bias scale is intended to assess exaggerated memory complaints. The way that RBS was developed was that the authors identified a group of civil litigants who had evidenced invalid, exaggerated memory problems on performance validity tests. And they also identified a group of litigants who did not evidence overreporting on performance validity tests. And RBS is comprised of items that differentiated between those two groups on the MMPI-2 restructured form. And thus, it's intended to assess exaggeration of memory complaints. The final two scales on this slide, uncommon virtues and adjustment validity, are intended to assess the third threat to protocol validity, which is underreporting. In other words, the minimization or outright denial of psychological problems when in fact psychological problems are present. The uncommon virtues scale is comprised of a variety of different items that are uncommon virtues. In other words, rarely claimed moral attributes or activities. So an example of the type of item that would be on LR would be something like, I have never sworn, or I have never told a lie. Again, individuals who respond true to these sorts of items are claiming uncommon virtues, and by extension are likely underreporting or minimizing their problems. And then finally, the adjustment validity scale assesses underreporting by way of the test takers' responses indicating an uncommonly high level of psychological adjustment. Before we move on from the validity scales, a brief discussion of how the validity scales are associated with malingering is needed. So malingering, of course, is the gross exaggeration or fabrication of psychological problems for some external gain. Examples of external gain would be something like for criminal defendants, obtaining a reduced sentence or a not guilty by reason of insanity verdict, or for disability claimants, obtaining disability payments. So first of all, it's important to point out that malingering and psychopathology are not mutually exclusive. So it is possible that somebody both has serious and real psychological problems while also malingering or exaggerating those problems or fabricating issues in other areas. Now, regardless of whether or not malingering is present, the MMPI-2-RF validity scales, if they indicate significant overreporting, this will definitely raise questions about the validity of scores on the substantive scales from the test, again, on which the overreporting was evidenced. And for this reason, scores in the substantive scales cannot be relied upon to assess for psychological dysfunction. Also, when elevations occur on the MMPI-2-RF overreporting scales, this does raise questions in general about the validity of the test taker's report, not only to the MMPI-2-RF, but also to other self-report inventories, or of course their self-report in a clinical interview. So we have our first review question for this module, and this is one where you have to pay pretty careful attention to get this correct. The MMPI-2-RF validity scales A, are all completely new scales, B, are all revised versions of existing MMPI-2 scales, C, are for the most part revised versions of existing MMPI-2 scales, or D, none of the above. The answer is C. If you paid very careful attention, one of the things that you would have noticed looking at the Validity scale slide was that some of the scales had a -R at the end of their abbreviation. And this -R stands for revised. So the scales that have been revised from their MMPI-2 counterparts are VRIN, TRIN, F, FP, FES, L, and K. So it's for this reason that the correct answer is C, that the MMPI-2-RF Validity scales are, for the most part, revised versions of existing MMPI-2 scales. Next, we move into the second unit of this module, where we will begin discussing the substantive scales. We'll start with the higher order scales.
The MMPI-2-RF higher order scales provide a broad indication of the individual's psychological functioning or dysfunction. They indicate whether and to what extent a test taker presents with problems in the domains of mood and affect, so emotional dysfunction, disordered thinking, so possible thought dysfunction, and their behavior, whether it's under control, so we may have some behavioral dysfunction. So they give us that indication of whether there are problems in one or more of those domains. They certainly can identify multiple problems. They also serve a very important function within the MMPI-2-RF of organizing the interpretation process. When we interpret scores on the substantive scales, that interpretation is organized into those three broad domains. So they have the dual purpose of giving us a broad assessment and an organizational structure for the MMPI-2-RF interpretation.
Next, we have the three higher order scales, which are emotional internalizing dysfunction, thought dysfunction, and behavioral externalizing dysfunction. These are three fairly broad measures of psychological problems. And they relate well to current issues in the assessment of psychopathology. So it's well understood that there's high levels of comorbidity between certain psychological disorders. Take, for example, depression and anxiety. They're both highly comorbid with one another, highly co-occurring. And some researchers have theorized that the reason for this comorbidity, or part of the reason for this comorbidity, is that psychopathology is actually structured in a hierarchical manner, such that there are broad constructs that some diagnoses share in common. So, for example, depression and anxiety, it's theorized that there's an internalizing construct under which both of those diagnoses fall. And so an individual who's high in internalizing is going to be likely to be diagnosed with both depressive disorder and an anxiety disorder. And what researchers in this area have found is that when you factor analyze common psychological disorders like depression, anxiety, psychotic disorders, substance use disorders, etc., what you'll find is that there's a three-factor higher order structure that's supported, where these diagnoses, their variance can be explained to a large extent by internalizing, thought, and externalizing issues. And so in this way, the higher order scales map onto current theories as to the structure of psychopathology. Interestingly enough, the way these scales were developed is Joseph Ben Porth and Alka Tellegen factor analyzed the RC scales, which are fairly comprehensive measures of psychopathology. And what they found from that factor analysis was a three-factor solution with these three constructs. So in addition, the development of these scales modeled common approaches to examining and defining the structure, the hierarchical structure of psychopathology. So we've reached our second review question for this module. Which of the following are true of the higher order scales of the MMPI-2-RF? A, factor analyses support this model. B, they provide a dimensional assessment of psychopathology. C, they help to provide an organizing framework for interpretation. Or D, all of the above. The correct answer is D, all of the above. All of these are true of the MMPI-2-RF higher order scales. And now we move into the restructured clinical scales of the MMPI-2-RF, which are actually identical to the RC scales from the MMPI-2.
The MMPI-2-RF restructured clinical scales, or RC scales, were developed originally for the MMPI-2 to assist in interpreting scores on the clinical scales, primarily by disentangling some of the overlap among the clinical scales that led to excessive correlations between them. To some extent, that overlap stemmed from overlapping items, but much of it came from the influence of demoralization, a general tendency that individuals have to feel unhappy, dissatisfied, distraught, or demoralized. So we measure that separately with the RC scales, and then each of the remaining 8 restructured clinical scales focuses on a major distinctive core component of the original clinical scales. In restructuring the scales, we also focused on linking each of the new scales, the restructured scales, to current concepts within the field of personality and psychopathology, so that we can link the interpretation to the broader literature on personality and psychopathology. And that's really how we use the RC scales on the restructured form as measures of important psychological constructs relevant to assessing for diagnostic evaluations and for treatment planning and other types of psychological evaluations.
On this slide, we have the restructured clinical scales, the first 5 of this set of scales. The first scale is RCD, demoralization, which measures general unhappiness and dissatisfaction. Other descriptors for individuals who score high on RCD include sad, distressed, depressed. Despite the fact that depression is listed as one of the descriptors, RCD is a non-specific construct that is present in a variety of psychological disorders, primarily mood disorders, but also other types of disorders. RC1, somatic complaints, is described as measuring diffuse complaints about physical health. The main types of somatic complaints assessed by RC1 are head pain complaints, neurological issues, and gastrointestinal symptoms. In the DSM-4, we had a somatoform disorder, which of course assessed medically unexplained somatic issues. In DSM-5, we now have somatic symptom disorder, which occurs when an individual has somatic complaints that cause significant distress or impairment. And to that end, somatic complaints can be a good indicator of somatic symptom disorder. The next scale is RC2, low positive emotions. This scale measures a lack of positive emotional responsiveness. In other words, this scale, individuals who score high on this scale have flat affect. And in this way, RC2 is a good specific indicator of, for example, major depressive disorder. However, RC2, low positive emotions, this construct can be present in other psychological disorders as well. Of course, we see flat affect in terms of the negative symptoms of schizophrenia, and also in terms of some of the symptomatology associated with post-traumatic stress disorder. Next, we have cynicism, which measures non-self-referential beliefs in terms of distrust, as well as a generally low opinion of others. Now, these distrustful beliefs are non-self-referential. What that means is essentially that they're not delusional, right? It means that in general, people cannot be trusted. That's what's being assessed by cynicism. And this construct in general has been implicated in two key areas. One is in the health domain, where individuals who are high in cynicism are at risk for cardiovascular disease. There's some landmark studies in that area with the original MMPI. And also the other major area of research on cynicism has to do with police officers, where cynicism is a risk factor for police officer burnout and misconduct. Finally, on this slide, we have antisocial behavior, which of course assesses rule breaking and irresponsible behavior. This scale is a good indicator of, for example, antisocial personality disorder. Here we have the final four restructured clinical scales. The first being ideas of persecution, RC6, which assesses self-referential beliefs that others pose a threat. In contrast to RC3, RC6 measures, again, self-referential persecutory beliefs. In other words, someone who scores high on RC6 thinks that people are bad and, in particular, are out to get them. And at high levels, this scale can be consistent with persecutory delusions. However, in some situations, some individuals are actually persecuted. So, for example, there are situations where an individual has experienced discrimination, perhaps based on race or social status or having a mental illness. And so you may see mild elevations in RC6 in those situations. The next RC scale is dysfunctional negative emotions, RC7. And here we have negative emotions that are problematic. These negative emotions including anxiety, anger, and irritability. Next we have RC8, aberrant experiences, which measures unusual perceptions or thoughts. Now, RC8 is the restructured version of Clinical Scale 8, which, of course, was called the Schizophrenia Scale. As you can see, it's not only been restructured, but it's also been renamed to aberrant experiences, and this is for a good reason. So, an individual who scores high on RC8 does not necessarily have schizophrenia. They experience some sort of aberrant experience. This could be due, for example, to drug use. Potentially, individuals with PTSD could have flashbacks that are forms of aberrant experiences, and so you could see high RC8 scores in that case. Or, of course, if somebody is experiencing hallucinations as a result of schizophrenia, they may also have a high score on RC8. But the point is that there's many different causes of these aberrant experiences, and so it's for this reason that all of the RC scales, including RC8, were renamed from their clinical scale counterparts, which were, of course, named after clinical syndromes like schizophrenia. Finally, we have the hypomanic activation scale. This scale assesses characteristics consistent with hypomania, and these are going to be more trait-level, chronic indicators of hypomania, including overactivation, aggression, impulsivity, and grandiosity. As we'll talk about when we get into specific problem scales, the best indicator of a manic state on the MMPI-2-RF is actually the activation-specific problem scale. We've come to our third review question. The MMPI-2-RF RC scales are blank to the MMPI-2 RC scales. A, all identical. B, for the most part identical. C, similar but not identical. Or D, greatly changed in comparison. The correct answer is A. The RC scales, whether scored from either the MMPI-2-RF or the MMPI-2, are identical. In Unit 4, we're going to discuss the specific problems and interest scales. Before we dive into the constructs measured by the specific problem scales, it's helpful, I think, to provide some background information for some context. So the restructured clinical scales, when they were developed, this was when the MMPI-2 was in use, and the purpose of the RC scales was to provide versions of the clinical scales with improved psychometrics. So the RC scales in of themselves don't assess everything that could potentially be measured by the MMPI-2 item pool. Now, when it came to the MMPI-2-RF, its goal was to derive a comprehensive set of measures representing the clinically significant substance of the entire MMPI-2 item pool. So to this end, the test authors augmented the RC scales with what we've discussed before, the higher order scales, and what we're going to discuss now, which are the specific problem scales.
The specific problem scales on the MMPI-2-RF are the most narrowly focused measures on the test. They are the ones that give us a much more detailed look at very focalized areas of potential dysfunction. They're not subscales. They can be interpreted regardless of whether we find clinical elevations on higher level scales, the RC scales or the higher order scales, but they can often help complement the interpretation and augment the interpretation of scores on those higher level scales. We have several sets of specific problem scales. We have a set that focuses on somatic and cognitive complaints, another set that focuses on internalizing difficulties. The next set of specific problem scales deals with externalizing behavioral tendencies, and then we have a set of scales called the interpersonal functioning scales that, as their label implies, focuses on various aspects on interpersonal functioning. We also have a set of scales called the interest scales that really are not measures of problems, but give us information about the types of interests a test taker might have. So overall, the specific problem scales really are designed to both give us more detailed information about problems identified by higher level scales, as well as new information that we're not able to obtain from other measures on the restructured form. Together with the higher order scales and the restructured clinical scales, the specific problem scales are designed to give us the overall picture of the individual's psychological functioning.
So as we discussed, the objective of the development of the specific problem scales was to augment the higher order and RC scales of the test with additional, more specific measures that tapped into other constructs potentially measurable by the MMPI-2 items. And there were four main areas where developing specific problem scales was of interest. So the first area had to do with measuring more narrow facets of some RC scales. So the RC scales are mid-level measures. Some of them are fairly broad in scope. So for example, RC4, antisocial behavior, includes a variety of different antisocial issues, including substance abuse and juvenile conduct problems. And so it's of interest to measure, for example, substance abuse separately from RC4 because of the importance of that construct, and also by measuring this construct separately as a facet of RC4, it aids in the interpretation of that RC scale. The next reason for developing specific problem scales had to do with clinically significant characteristics that were not represented by either the clinical or RC scales. So there's no clinical scale or RC scale that measures suicidality. This, of course, is a construct of interest, and there are a fair number of suicidal and death ideation items on the MMPI-2, and for that reason, the suicidal ideation specific problem scale was developed. Also, there were no RC scales developed for clinical scales 5, masculinity, femininity, or 0, social introversion. So some specific problem scales were developed to assess these areas. And then finally, when the RC scales were developed, again, they're revised versions of the MMPI-2 clinical scales. And the MMPI-2 clinical scales, of course, were fairly heterogeneous scales. So, for example, Scale 3 measured a variety of different constructs, including naivete and social anxiety. Naivete ultimately was what ended up being measured by RC3, cynicism. If you just reverse naivete, it's equivalent to cynicism. But social anxiety, that component, is also of interest for measurement. And so the shyness specific problem scale was created to assess social anxiety. We now will move into the constructs assessed by the specific problem scales, and we'll move through these scales a little bit quicker because there's over 20 of them. But before we get into the constructs, they are organized, the specific problem scales, into different substantive domains. So the first domain of specific problem scales that we are going to review are the somatic cognitive specific problem scales. All 5 of these serve as facets of RC1. The first scale here is malaise, which is an overall sense of physical debilitation and poor health. In many ways, this scale is similar to demoralization, except in the case of malaise, this is a non-specific construct to many medical conditions as opposed to psychological problems, as is the case with demoralization. The next 3 scales are gastrointestinal complaints, head pain complaints, and neurological complaints. You might recall that earlier I said that these were the 3 primary areas assessed by RC1, somatic complaints. So with these 3 scales in particular, they're very helpful in fleshing out the reasons for elevations in RC1. And then finally we have the cognitive complaints scale, which assesses memory problems and difficulties concentrating. Again, all 5 of these are facets of RC1 that can be used to better interpret it. That being said, there will be cases where there is no elevation on RC1, but there is an elevation on these scales, and in that case, these scales are still interpretable. So they're not subscales in the truest sense of the word. They're facets of RC1. On this slide, we have the first 4 of the internalizing specific problem scales. And these 4 scales are facets of RCD demoralization. The suicidal death ideation scale provides direct reports of suicidal ideation and recent attempts. These are very face-valid, critical items that are indicative of suicide risk. The next scale is helplessness, hopelessness, which is a belief that goals can't be met or problems can't be solved. And then finally, we have self-doubt and inefficacy. So these 2 scales measure constructs that are closely related, but that are distinct. So whereas self-doubt is a lack of confidence in oneself, inefficacy is a lack of confidence in one's ability. On this slide, we have the rest of the internalizing specific problem scales, and all of these are RC7 facets, and as a reminder, RC7 measures dysfunctional negative emotions. Stress worry assesses preoccupation, disappointment, as well as difficulty with time pressure. This scale is a good indicator of obsessive compulsive disorder, as well as generalized anxiety disorder. The anxiety scale assesses anxiety, frights, and frequent nightmares. This is one of the best specific predictors of post-traumatic stress disorder on the MMPI-2-RF. Next, we have anger proneness, which measures being easily angered and impatient with others. This scale is often a good indicator of personality disorders like borderline personality disorders. And then we have behavior restricting fears, which assesses fears that significantly inhibit normal behavior. You'll often see this scale elevated in cases of agoraphobia. And then finally, we have multiple specific fears. These are a variety of different phobic types of fears, like fears of blood, fire, and thunder. On this slide, we have the 4 externalizing specific problem scales. The first 2 are facets of RC4, antisocial behavior. Juvenile conduct problems assesses difficulties at school and at home, as well as stealing. This scale is useful for the identification of antisocial personality disorder, which of course has a criterion that specifies that the individual must have had conduct problems as a juvenile. Next, we have the substance abuse scale, which assesses current and past misuse of alcohol and drugs. Most of the items on this scale assess alcohol use, but there are items that assess marijuana use and illicit prescription drug use. We have next the externalizing specific problem scales that are facets of RC9, which is hypomanic activation. The first scale here is aggression, which measures physically aggressive and violent behavior. The aggression scale is a pretty face valid indicator of aggression, with questions like I enjoy getting into physical fights. And next we have activation, which as we discussed earlier is the best indicator of a manic episode on the MMPI-2-RF. Here we have the specific problem scales that measure interpersonal functioning. Family problems assesses conflictual family relationships. This scale is helpful in a variety of different contexts because, of course, family problems is a risk factor for a variety of different psychological problems in adulthood, including depression, suicide risk, substance abuse, and other issues. Interpersonal passivity measures being unassertive and submissive. This scale can be a good indicator of whether or not individual has social support, wherein individuals who are passive are less likely to utilize social support. The final 3 scales here, social avoidance, shyness, and disaffiliativeness, all have to do with social isolation. Social avoidance being avoiding and not enjoying social events. Often when there's an elevation on social avoidance, it's useful to look at shyness and disaffiliativeness as potential causes for that social avoidance. Shyness being reflections of social anxiety, and disaffiliativeness involving disliking people and being around them. So these are 2 different reasons why an individual may avoid being around others. And finally, we have the 2 interest scales, which were developed from components of Clinical Scale 5, Masculinity, Femininity. And these 2 interest scales include aesthetic literary interests as well as mechanical physical interests. For our first review question for this unit, the MMPI-2-RF somatic cognitive scales are A, subscales of RC1, B, can only be interpreted if RC1 is elevated, C, both A and B, or D, none of the above. The correct answer is D, none of the above. Recall that the somatic cognitive scales are facets of RC1, not subscales, and they can indeed be interpreted if RC1 is not elevated. Here's a tricky one. The MMPI-2-RF internalizing specific problem scales assess facets of A, RCD and RC2, B, RC2 and RC7, C, RCD and RC7, or D, RCD and RC8? The correct answer is C. Recall that there are 4 internalizing specific problem scales that are facets of RCD, and that, of course, was suicidal ideation, helplessness, hopelessness, self-doubt, and inefficacy. And then there's 5 internalizing specific problem scales that are facets of RC7, and those include stress worry, anxiety, anger proneness, behavior restricting fears, and multiple specific fears. We've reached the final unit of our module, which is on the Personality Psychopathology 5 scales. At scores that are within normal limits, these actually assess normal personality traits, but when clinical elevations occur, it's indicative of abnormal personality traits.
The MMPI-2-RF Psy-5 scales are revised versions of Psy-5 scales that were first developed for the MMPI-2. The Psy in Psy-5 stands for personality and psychopathology. So these are measures of personality psychopathology constructs related to, in particular, understanding individual differences relevant to personality disorders. Traditionally, personality disorders were diagnosed using a categorical approach as either being present or absent, but increasingly we're recognizing that individual differences in personality traits predispose individuals to perceive their world in a certain way, to interact with others in certain manners that can be dysfunctional and lead to personality disorder. So with the MMPI-2-RF, we have revised versions of the scales that focus on and rely on the items of the restructured form that give us that dimensional perspective on personality disorder-related psychopathology.
As you just saw in the video, the Psy-5 scales, as they're called, provide a validated dimensional evaluation of personality disorder characteristics. And in many ways, this is similar to the model of personality disorders that was considered for inclusion in the DSM-5. Some of you may remember that there was consideration of having a dimensional as opposed to categorical model for the personality disorders. That proposal was ultimately tabled and designated as needing further research by the American Psychiatric Association. But for this model, there was a measure developed to assess the 5 broad dimensional factors of personality pathology. And this measure was called the PID-5, or the Personality Inventory for DSM-5. And the 5 dimensions that were measured by the PID-5 included negative affectivity, detachment, antagonism, disinhibition, and psychoticism. And research indicates that these 5 measures converge with the Psy-5 scales. And it is important to note that the Psy-5 scales were developed in the early 1990s for use of the MMPI-2 well before this proposal for DSM-5 and the development of the PID-5 a few years ago in the early 2010s. These are the 5 personality psychopathology scales. One of the things I'll point out here before we begin is what you'll notice is all of the scales after their abbreviation have a -R. And that should look familiar because we saw the same thing with some of the validity scales. The -R stands for revised. So the Psy-5 scales were initially developed for the MMPI-2, and they are included in the MMPI-2 score report. And these versions of the scales are revised versions for use with the MMPI-2 restructured form. The first Psy-5 scale is aggressiveness, And in contrast to the aggression scale, which is a specific problem scale, the aggressiveness scale measures instrumental aggression. In other words, aggression for a particular aim. The psychoticism scale measures disconnection from reality. Disconstraint measures impulsivity and under-controlled behavior. Negative emotionality, neuroticism, measures temperamental anxiety, insecurity, worry, and fear. And then finally, the introversion low positive emotionality scale measures temperamental social disengagement and anhedonia. The Psy-5 scales not only provide a dimensional assessment of personality disorders, but they can also be linked to the current categorical diagnoses in the DSM-5. And it's best to link the scales to the DSM-5 by way of the personality disorder clusters. So aggressiveness and disconstraint are measures of cluster B personality disorders, the dramatic and erratic ones. These include antisocial and borderline personality disorder. Psychoticism is a measure that can be linked to cluster A, the odd, bizarre, and eccentric personality disorders, such as paranoid, schizoid, and schizotypal personality disorder. Then finally, negative emotionality and introversion can be tied to the cluster C personality disorders, the anxious and fearful ones, including, for example, avoidant and obsessive compulsive personality disorders. We've now reached our final review question. The Psy-5 scales may be A, linked to clusters of personality disorders in the DSM-5, B, represent broad factors associated with normal functioning and personality, C, revised versions of MMPI-2 measures of the Psy-5 dimensional model of personality pathology developed by Harkness and McNulty in 1994, or D, all of the above. The correct answer is D, all of the above.